Bladder management assessment and interventions for SCI populations are easier than you think. In this video, I'll show you how to seamlessly integrate them into your OT practice. Stick around to learn how. Welcome back to video 4 in the series, where we talk about the role of OT in BBM. I'm Julia, and today we'll focus on how to develop an OT-specific plan of care for managing neurogenic bladder. We'll cover how to add a non-standard bladder function assessment to your plan of care, common toileting barriers by SCI level and how to address them, and examples of long and short-term goals for your clients. I've also linked supplemental handouts and resources in the video description below, so make sure you check those out. Let's dive in. Before we get into assessment and intervention, let's zoom out and look at the big picture. What exactly are we trying to accomplish in a bladder management program? At its core, the goal of bladder management OT is twofold: helping clients maximize independence in toileting and preventing complications like UTI, autonomic dysreflexia, and hospital readmissions. And why does this matter? Because better bladder management equals better quality of life. The less time clients spend with preventable complications, the more time they have engaging in meaningful activities. Now, here's the good news. You don't need to reinvent the wheel or add a ton of extra steps to your evaluation process. By simply shifting your lens to include bladder function, you can gather everything you need while conducting your standard OT assessment. Let's start with a chart review. This is where we gather key information about your client's level of injury and motor and sensory function using the ASIA impairment scale. If you remember from video 2, spinal cord injuries are classified as either upper or lower motor neuron lesions, which directly impacts bladder function. As a review, injuries at or above T12 equal upper motor neuron lesions and result in reflexive or spastic bladder. On the other side, we have injuries below T12, which is a lower motor neuron lesion, and result in areflexive bladder symptoms, also known as flaccid. Seems pretty straightforward, right? Well, not always. While these classifications are helpful, injury level alone doesn't always tell the full story. Some individuals may still have lower motor neuron involvement due to concurrent injuries or still be experiencing spinal shock, a temporary condition where reflexes are absent. These conditions can alter bladder function, meaning that a person with an injury above T12 might still present with areflexive bladder symptoms. To address this, we'll need additional information, either from a patient's chart or later from our non-standard bladder function assessment, which will be discussed later in this video. Now, let's shift gears and talk about hand function. Bladder management is more than just bladder function. It's also about whether the client has the dexterity or the motor control to perform self-catheterization. Individuals with SCI typically fall into 3 functional groups based on hand function. The first group that we have is C1 through C5, where we typically have an absence of hand function. This group typically requires full to max assist in bladder management. The next group we have C6 through C8, where we have limited hand function. This group has the potential for full independence in self-catheterization with adaptations. And lastly, we have the T1 and below group, where we typically see full hand function. In this group, self-catheterization is typically achievable with much fewer to no adaptations. Knowing all of this ahead of time helps us predict challenges and plan targeted interventions. Next, we start our actual evaluation. We already assess home setups and support systems, so consider these environmental barriers to toileting early on. Setting up a mock environment in an ADL suite can help clients practice toileting in a realistic setting. On to our motor function assessment. This tells us where your client is starting in their recovery journey. Again, in terms of bladder function, we direct our focus on upper extremity range of motion, strength, dexterity, and trunk control. The presence of functional tenodesis is game-changing, and that's typically seen at the C6 level of injury, as it'll support the gripping needed to manage a catheter. Additionally, we want to know any spasticity that is observed, as lower extremity spasticity can affect body positioning, required for lower body clothing management. And finally, observing ADL performance in toileting will shape our intervention strategies. Watching a client dress, transfer, and manage functional mobility helps identify toileting challenges early and should be targeted in your plan of care. Now, here's where we augment the initial evaluation process. To assess neurogenic bladder symptoms and their impact on independent toileting, we want to conduct a structured clinical interview. Key areas to address include current bladder routine and independence, sensation and voiding symptoms, and complication and risk factors. For current bladder routine, we want to know, when did they transition from an indwelling catheter to CIC. This helps gauge their adjustment period. What is their current level of independence with CIC? Have they attempted self-catheterization, or are they still relying on nursing staff? What is their catheterization schedule? Their output volume? Are there any color or sediment changes? This can indicate hydration levels, possible infections, or any other health concerns. What does their daily fluid intake look like? Consider both quantity and type. Are they drinking mostly water? Or are they consuming mostly caffeinated drinks, which could impact bladder health? Next, and for sensation and voiding symptoms, we want to ask about their awareness of bladder fullness and frequency of sensation, ability to fully empty the bladder, or feelings of incomplete voiding, occurrence of urinary accidents, including frequency and common triggers like sneezing or body positioning. And lastly, for complication and risk factors, we'll look into presence of pain, burning, or discomfort during urination or catheterization, and history of urinary tract infections, or UTIs, including frequency and recurrence. Once we've gathered all of the necessary information from the evaluation process and the non-standardized assessment of bladder function and the symptoms, we should have a pretty good snapshot of where they are on their bladder management journey. So let's move on to common barriers that clients face when trying to manage their bladder programs. Common challenges seen at this stage include, but are not limited to, anxiety with the prospect of self-catheterization, limited understanding of the urinary system, anatomy, such as the female urethral opening, and risk of secondary genitourinary complications such as UTIs or kidney stones, limited bed mobility and functional transfer capability, largely due to postural instability, decreased trunk control, and upper extremity weakness, presence of lower extremity spasticity affecting body positioning, limited dexterity depending on the level of injury or muscular weakness, difficulty with lower extremity positioning and lower body clothing management, and finally, poor visualization due to body habitus or low lighting. Now for the fun part. To address these barriers, we can structure our plan of care around three main intervention approaches: create, promote, establish, restore, or adapt and modify. Through create, promote, we can educate our client about the urinary system, basic anatomy, importance of bladder management routine, and how it prevents complications like UTI and autonomic dysreflexia. Trauma-informed care is also key in this area by validating potential fear and anxiety surrounding CIC with proper teaching. For example, explaining what you're doing during CIC step by step and what to expect along that process can help ease a client with anxiety around CIC. Really, it all comes down to compassionate care. Next, we have the time voiding schedule. We can team up with the nursing staff to create a personalized schedule for CIC or time voiding. This includes specific catheterization times or emptying a urine collection bag. Next, we can introduce the concept of a bladder diary to track things like output volume, color, and sediment, so we can adjust the plan as needed to help clients stay on top of their bladder health. Next, through Establish Restore, we can focus our sessions on strengthening and improving coordination needed for body positioning, transferring, and seated balance training to support safe and efficient catheterization. Lastly, through Adapt and Modify, we get to be creative and find individualized solutions for our clients with adaptive equipment or activity modifications. Some examples of AEE to consider include catheter guides, catheter inserters, or specialized clothing. Some modifications include adjusting toileting positions, such as being propped up in bed, circle sitting in a wheelchair, or transferring to the toilet. Other considerations include extension tubes or different collection containers, as these modifications can be game changers for someone who's just starting to cath. By combining these strategies, we help clients feel confident and more independent in their bladder management. On to long and short-term goals. We already mentioned at the beginning of the video that the goal is to maximize independence in toileting. However, some specific goals that you can include in your documentation include: client will independently perform CIC using adaptive equipment, such as a catheter guide or grip aids, in a seated position in 3 weeks to support full independence in bladder management. A short-term goal to support this could include something like this: client will maintain upright seated balance without upper extremity support for 3 minutes while completing CIC setup and catheterization within 2 weeks to improve independence and safety in bladder management. Another short-term goal: client will independently adhere to a timed CIC schedule using bladder diary and external reminders, such as a smartphone or an alarm, with 90% accuracy within 2 weeks to improve continence and support safe and effective bladder management. Before I wrap up, I want to mention that some clients may need long-term catheterization, like a suprapubic catheter, or may opt for a Mitrofanov procedure, depending on their injury level or ability to perform CIC. In these cases, goals should focus on training and adherence to draining schedules to support maximized independence and prevent complications. Now, I know that was a lot of information, especially if you're new to the world of bladder management, but here are the takeaways. A small shift in the evaluation process is all it takes to integrate bladder management into OT practice. A non-standardized bladder function assessment conducted through a clinical interview helps guide your plan of care. And finally, using a mix of intervention approaches ensures a client-centered approach to maximizing toileting independence. If you found this video helpful, be sure to check out video 5 and 6, where I go over adaptive equipment and catheter options specific to spinal cord injury levels. See you there.